All right, everyone. Well, we will probably continue to see a few more trickle in, and I will continue promoting everybody to panelists. So you will have control of your microphone and your video in case you want to interact. But this month we have Dr. Becca Serpata joining us today, which I'm very excited about. She is a psychologist who works for both U of M and the VA and does a lot of research on post-traumatic stress disorder, particularly prolonged exposure for primary care. So I think she has a lot of really valuable information to share with us today. And Becca, for some background, this is the Integrated Behavioral Health Learning Collaborative. This is something that we have been doing for a few years between U of M and IHA's Collaborative Care Department, where we get together once a month and learn a new topic.
Great, thank you. Thanks so much for having me. I'm going to share my slides. There we go. Okay. So I'm going to be talking with you today about post-traumatic stress disorder and some work that I've done with treatment for PTSD in the primary care setting. And as Courtney mentioned, I am a faculty member at University of Michigan in the psychiatry department, and I also have an appointment at the VA Center for Clinical Management Research. And I'm a psychologist by training. And I want to acknowledge some of the funding I have for these projects. I have an award from the Michigan Mental Health Integration Partnership Scholars Award, which is a combination of University of Michigan Depression Center funding and matched with Michigan Department of Health and Human Services. And I also have a Rachel Upjohn Award from 2020, and I have a Career Development Award from VA Health Services Research and Development. So as you know, post-traumatic stress disorder is a debilitating mental illness that's characterized by re-experiencing symptoms, avoidance symptoms, negative alterations in mood, and hyperarousal. And it's associated with myriad negative health outcomes, including decreased quality of life and increased risk of later life physical disability and lost productivity, suicidal ideation, and suicide attempts. And unfortunately, it's a growing problem both in and outside of the VA. So we know that it affects about 7% of the general population and 400,000 United States veterans. And of those who use the VA, of the returning veterans, it affects up to 23%. This data comes from the National Academy for Sciences, Engineering, and Medicine. And you can see from this table that it's more prevalent than any other mental health condition among returning veterans, and pretty prevalent among non-veterans as well. And although we reportedly do a really good job in VA of treating PTSD, we have significant gaps in our care delivery. So we have good treatments available, but not everyone is receiving those treatments. And along with my colleagues, I've done some work with nationally representative surveys, taking a look at how often people receive care for PTSD. So in the general population, only 30% of people with a current PTSD diagnosis who currently meet criteria for PTSD receive any kind of care for PTSD. And that could be medication or psychotherapy. It could be evidence-based or non-evidence-based, just any therapy at all or any treatment at all. And then of those who are seen in VA, when PTSD is identified in the primary care setting, only 50% of people receive any kind of treatment and only 14% receive specialized treatment. So what I'm hoping to do today is help you understand the diagnostic criteria for PTSD. I'm hoping that you'll be able to describe some PTSD treatment strategies, understand the problem of attrition, dropout from our therapies, understand the treatment adaptation process, and describe prolonged exposure for primary care. I'm also hoping, if it's okay, to hear from you a little bit about what your experience is treating PTSD, what would be helpful for you in treating PTSD in your setting, and furthering my own education. So a little more detail about what I'll be covering. We'll look at the diagnostic criteria, the treatment options, the evidence-based treatments for PTSD, and some options for how this might be delivered in a brief treatment setting. So I'm going to start off by talking about what PTSD looks like. So PTSD can develop after a number of different traumatic events. It can be from combat. That's what people most commonly think of, I think, with PTSD, but it also can occur after sexual or physical assault and PTSD. And a sexual assault is the trauma that is most likely to lead to PTSD, actually. It can occur after learning about the violent death of a loved one, after sexual or physical abuse, after serious accidents or natural disasters or terrorist attacks. And I have hyperlinks throughout this presentation, and you should be able to, and I think you'll have a copy of the slides. So if you want to take a look at these resources, you'll have them available. So I'm just going to show you a brief video, if I can figure out how to make this work, to show you what it's like for someone to go through PTSD or to have PTSD. And this is from a website called the National Center for PTSD website. They have a specific section called About Face. I'm going to be showing a few videos from it. I think it's a really useful resource to potentially give to patients so that they can see what it's like for other people with PTSD. Okay, so I'm going to do a new share, and let me know if you're unable to, I'm going to share sound. Let me know if you're unable to hear this.
No sound yet.
I think it's back.
Anytime a helicopter went over, that affected me very much because I saw some guys die in a helicopter. Well, actually 2 helicopter crashes in Vietnam.
The biggest trigger for me is smell.
I do have a lot of nightmares. They have to do with what happened out there, most of them.
I was in Arabic class, and I remember the teacher. Like, I remember him lecturing us, and I looked out the window, and all of a sudden, I started seeing things that weren't there. I really thought my rapist was there. I really thought he was going to come in the window and get me.
Before going to Iraq, I really didn't understand what road rage was. I couldn't understand why people would get so angry, and I found myself really furious at people who would do things, not even necessarily cutting me off and being dangerous, but just stupid things.
Back in the days when I was going through what I call my Chernobyl period, I slept 1 or 2 hours every other day. And I never slept without a loaded gun and a survival knife near me.
A lady was coming towards me in a hurry, and she dove right into her purse. And the first thing I did instantly was, I need to protect my nieces. I started scooting in behind the pillar, started moving away, and I instantly went reaching for my hip, realized, wait, I don't have a knife or a gun. And this happened in like 3 seconds, and all she did was, in my head, all I was thinking was gun, 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 gun. She's going to pull a gun on me. And all she did was get her cell phone.
Sometimes I really can't leave my house.
When I first came back, I couldn't even walk in Walmart. I had a real hard problem going to Walmart. I'd hear people talk from a different language, and it put me on edge. I would literally back up against the aisle in the wall and watch the aisle down until they passed if they were behind me.
I used to disappear on weekends and just drive. Come home on Monday morning and go to work. They understand why I would do things like I would drive to New York City to get a cup of coffee at night and drive home. Driving became my release. They couldn't understand that at the time. They do now. They realize that I just had to do that.
The emotional numbness, I think, is the most. It'll just tear away all the relationships in your life.
I don't want to have to try and explain it to people, and I didn't want to have to go over my experiences every single time to try and let somebody know. And so it's much easier just not to have friends.
Everything I did was wrong.
The war in Vietnam was my fault. Anyone who died there, I might as well have pulled the trigger. It was my fault. So therefore, I probably wasn't worth helping.
I trusted no one, absolutely zero trust, even in my own family, my own sons, my immediate family, and friends that I had. Lost total trust in my friends because I felt like if I trusted somebody and somewhat opened up, I was going to get hurt.
If you're going around saying everybody else has a problem and it's not me, chances are, yeah, you're the one with the problem.
Okay. So as you can see, PTSD takes a variety of forms, and it has a big impact on functioning. Let me resume my slideshow. And it can look different for different people. What I'd like to do, if it's okay, is it would be great to hear if any of you have treated folks with PTSD and what it looked like for them. Did it look like these folks? What was PTSD like for those individuals?
And feel free to unmute yourself.
So I had a patient, it's a woman in her 30s, who in very short order saw her mother die in her arms, had a horrible C-section situation with having a baby, and had a blood clot afterwards.
Wow.
And so I don't see the avoidance symptoms quite as much, but boy, the reemergence symptoms, like she went to the ER for potential COVID the other day, and all she could think was that she was going to have another blood clot while she was there. And so, and she can't drive. Oh, I guess avoidance. She can't drive by the place where her mother died. So, yeah.
Yeah, so it's like she had sort of multiple traumas stacked on top of each other. And certain events right now are making those re-experiencing symptoms even more salient and even more problematic for her. Yeah. Yeah, so, I'm glad you brought that up because it's, we sometimes think about PTSD as just happening with those that have combat experience, but it can happen with any type of trauma. People can develop PTSD symptoms from that. Okay, so let's talk a little bit more about the diagnostic criteria. This was a good review for me because the diagnostic criteria have changed recently, and the diagnosis is actually pretty broad, so it can look different for different folks. So the first criterion is to have a traumatic event that meets what we call A1 criteria. And so that can be directly experiencing the traumatic event or witnessing the event as it occurred to others. It can be learning that the event occurred to someone, to a close family member, or experiencing repeated or extreme exposure to the event. What it does not include is social media or other media exposure to traumatic events unless that's part of your job. Then the intrusive symptoms, the re-experiencing symptoms that Lori was mentioning, can include recurrent and involuntary and intrusive distressing memories of the event. So when we talk to patients, we talk about memories that come up out of the blue, even when you don't want to be thinking about the event. Then recurrent distressing dreams related to the traumatic event. People oftentimes have nightmares about other topics as well, but in order to meet this criteria, we're really looking for nightmares about the trauma. Dissociative reactions are flashbacks, and this is any time when the individual feels like the event were recurring. It doesn't often meet the level of losing touch with where you are, but oftentimes people will say that they smelled something and it really kind of felt like it brought them back there, or they felt partially transported back to the time of the event. Another intrusive symptom is intense or prolonged psychological distress. at exposure to internal or external cues. So being very upset when something reminded you of the event. And then a marked physiological reaction to internal or external cues. So having a strong physical reaction when something reminded you of the event. And these re-experiencing symptoms are really salient and really distressing for folks. The next cluster, oh, and feel free to interrupt me at any time if you have questions. I should have mentioned that at the beginning. The next cluster of symptoms is avoidance symptoms. And this is avoidance or efforts to avoid internal stimuli, so distressing memories and thoughts or feelings. We describe this as trying to push away the memories or the thoughts about the trauma when they come up. And it also entails avoidance or efforts to avoid external reminders. So avoiding the places, people, conversations, situations that bring up memories about the event. And these avoidance symptoms are what we think, both the avoidance of both the internal and the external reminders are one of the big drivers of PTSD symptoms. If avoidance in the early days can lead to higher likelihood of developing PTSD. The next cluster of symptoms is alterations in mood. So in order to meet criteria, you would need to have 2 of the following symptoms. It could be inability to remember an important aspect of the trauma, although I don't see this as much in practice. It could be persistent and exaggerated negative beliefs or expectations about yourself or the world. So thoughts like I'm a bad person, or thoughts about others like I can't trust anyone, like we saw in the video, or thoughts that the world is a very dangerous place, or that my nervous system is ruined. Then persistent distorted cognitions about the cause or consequences. So this is putting undue blame on yourself or undue blame on other people. And then another symptom is persistent negative emotional state. So fear, horror, anger, guilt, or shame. This includes diminished interest or participation in significant activities. Then feelings of detachment or estrangement from others. And persistent inability to experience positive emotions. So this is what we refer to as emotional numbing. And this can be particularly painful for people. And so you can see that these symptoms do overlap with depression a lot. So it's very common to have comorbid depression when you have PTSD. The next cluster is hyperarousal symptoms. So this is what we talk to people about as your fight or flight system being in overdrive. And these are marked alterations in arousal and reactivity, such as irritable behavior and angry outbursts, like the woman in the video who had road rage that was new, reckless or self-destructive behavior, hypervigilance, so always being on your guard or on edge, exaggerated startle response, so having a very strong response when someone startles you, problems with concentration and sleep disturbance. And then finally, in order to meet criteria for PTSD, these symptoms all need to be around for at least 1 month. So it's before that, it's acute stress disorder, and after the 1 month marker, it becomes PTSD. And then the disturbance cause clinically significant distress or impairment, and you wouldn't attribute this to a substance or another medical condition. And I put a little caveat here that you don't necessarily need a full diagnosis to benefit from treatment. You know, in particular, we've done studies with the adaptation. I'll talk to you about prolonged exposure for primary care, just with people who self-report or meet criteria by a self-report measure. So we didn't do a full diagnosis necessarily, but if you're looking for the full diagnosis, these are the criteria you would look at. Any questions before I move on about the diagnosis of PTSD or the diagnostic criteria?
Doctor, will you be speaking at all about developmental PTSD, complex trauma that occurs over developmental periods in adolescence and childhood, and how that differs from this traditional view of PTSD?
So something like complex PTSD?
Yes.
So I think that, you know, if you look at different classification systems, there is this complex PTSD diagnosis. We don't see that as much with DSM, but you know, the treatments that I'll be discussing have all been tested in individuals with a variety of trauma exposure. So, so I guess the answer is I haven't planned to, but if you have specific questions about it, I'd be happy to answer them.
Not at this time. I was just curious. Thank you.
Sure. So, but I'll keep that in mind. I'll try to weave that into some of the treatment talk. So, you know, one question you might have is what the best way to identify PTSD might be. And so, you know, you probably don't have time to go through the full diagnostic criteria with everyone. So a brief screener that I would recommend is the PC-PTSD-5, which is the primary care PTSD screen for DSM-5. And I've put the link to the measure up at the top of the screen here, and it's a freely available measure. And this has pretty good sensitivity and specificity. There's one question to assess whether the individual has experienced trauma, and then 5 questions to assess the symptoms. So the first question is, have you experienced an accident or physical sexual assault, earthquake, war, etc. And then the 5 questions that are asked subsequently are, have you had nightmares about this event? Have you tried hard not to think about this event? Have you been constantly on your guard? Have you felt numb or detached? Have you felt guilty or unable to stop blaming yourself? So this hits on the major diagnostic criteria for PTSD. And if someone scores above a 3 on this measure, then they would merit further discussion. They may quite likely have PTSD. So now I want to spend some time talking about the treatment options for PTSD. But before I do that, it would be great to hear from you again, if you're willing, to tell me a little bit about how PTSD is treated in your setting and how you treat PTSD. Don't everyone speak at once.
I mean, to be frank, it's typical that for, at least if this is primary or complex, these are folks that we refer out from primary care. So it's not that you can't have PTSD, but if this is your presenting problem, we tend not to enroll them in behavioral health collaborative care.
Okay. And what are there like folks in the community that you tend to refer people to for PTSD treatment, or?
I know that we're often told to refer to a therapist that's trauma informed or has experience with PTSD. I always find it incredibly difficult to identify those in the community that have this type of specialty. So it can be difficult to try to figure out who those people are.
Yeah,
I would agree. So this is Pat Ryan. So I was a private practice psychiatrist before doing this behavioral health collaborative care work, and trying to find some, like a lot of people sometimes say they're trauma therapists, know how to do that. But really finding people who really know how to do this, I think, is difficult. I knew a few people who did EMDR. So that's typically what those are the people that I would refer my patients to.
Yeah, so what I'm hearing is that if someone has PTSD, then they usually get referred to care with a focus on PTSD, but it's not that easy to find those who specialize in PTSD or to be all that clear on the type of treatment that they're delivering. Okay, yeah, I think it's a real problem, and it's not easy to find this in the community. So I'm really interested in finding ways to make it easier to treat in the primary care setting. So So the guidelines for treating PTSD are to, first provide trauma-informed care, and I gave a link to that here, which is a strengths-based treatment framework. And it involves a lot of the things that are already part of collaborative care, such as shared decision-making, where you're talking with patients about the options and about what the evidence suggests and finding and discussing with them what would be the best fit for their needs. And then diagnostic evaluation, with a screener, and then potentially a slightly longer measure, which I'll show you later, which is the PCL5, which is a 20-item self-report measure, to just give you a little bit more information about PTSD symptoms. And then treatment or referral. So for medications, the FDA-approved medications are sertraline, paroxetine, fluoxetine, and venlafaxine. And then for therapies, I'll be talking with you about 3 different types of evidence-based treatments that have the strongest evidence to support their efficacy: prolonged exposure, cognitive processing therapy, and EMDR. So we'll start with prolonged exposure therapy. This is the treatment that probably has the greatest effect size for PTSD. So prolonged exposure is based on the idea that PTSD is really driven by that avoidance. That avoidance in the early days prevents recovery and can lead to an exacerbation of the other symptoms. And full prolonged exposure consists of 10 to 12 psychotherapy sessions. Each one is 90 minutes long. And it includes the core components of PE are in vivo exposure and imaginal exposure and facilitating emotional processing. So for in vivo exposure, basically what that is starting to confront and approach the things that you've been avoiding. So we systematically lay out the list of things that people have been avoiding because it reminds them of their trauma. So situations that are objectively safe but perceived as dangerous because they remind the individual of a traumatic event. And we start to progressively work our way from the easiest up to the hardest situations to help people really take back their lives. And in vivo exposure is used for, not just for PTSD, it's used for a variety of anxiety disorders, but it's a really powerful tool here. And then for imaginal exposure, which is somewhat more unique to PTSD, we confront the trauma memory itself, because that's a big component of PTSD is pushing that trauma memory away. And what we tell folks is that the more you push it away, unfortunately, the more often it comes back. And so what we do in prolonged exposure is we have the individual recount the trauma memory in session with the therapist. And we do that for a big chunk of the session, and then we process it. We discuss how it's impacted them and impacted the way they see themselves and other people. So the structure of PE is that we start in vivo exposure at session 2, we start imaginal exposure at session 3, and then we start the emotional processing at session 3 following the imaginal exposure. So I'll tell you a little bit about a patient that I treated with PE whose trauma was a motor vehicle accident and a subsequent ICU stay. So this individual was in a very bad car accident at an intersection and then had a traumatic time in the ICU. So his trauma was kind of both the accident itself and then his time in the hospital, and really related to his loss of his sense of control during his time in the ICU. And so for this individual, the imaginal exposure, initially was that whole day. But as we progressed, we found out that really it was the time in the ICU that was the most traumatic and the most upsetting. So that's when you do prolonged exposure, you initially start with the full trauma memory and then kind of zero in on the most upsetting part. So we ended up spending more time on his time in the ICU because that was the most upsetting part for him and the most traumatic part. And then in terms of the in vivo exposure, he was having a hard time driving because every time he drove, it brought up this fear and this memory of the event. So we started off with just driving in places that he felt relatively comfortable in that were not too busy. And then we progressed to driving through intersections. And then we eventually got to the point where he was able to drive through the intersection where he had had the accident. So that he really was not limited anymore by the PTSD in this regard. So I'm going to share with you another example, just a brief clip about someone who went through PE and what their experience was like. That one. Okay, here we go. Oh, I think I might have done the wrong share. Let me try it again. Yes, I did that right. Okay.
Was to listen to that tape every day with my eyes closed. Assignment was to listen to that tape every day with my eyes closed, and to keep a pad and a little cheat sheet that she gives you actually, and I would write down my number when I felt myself fall apart. And then the second week I went back, the same process was repeated. The third week, the same process was repeated, and so on until about, I would say, 4 or 5 weeks into the process. My breakdowns during the taping were so different. So I would say the first time I did it, that was hard pain. By 4th or 5th week, it felt like a soft pain, just soft and sad. And every week before we started this process, she would give me the tools again to rate my symptoms for PTSD, for depression. And she would tell me what they were. There were no secrets in this therapeutic process.
Okay. Oh, it's still going. I thought that was someone in the audience. Okay, so let me go back to the PowerPoint. So any questions about prolonged exposure therapy? Oh, and I wanted to mention, speaking of, the range of presentations and the range of types of PTSD, that PE definitely can be done with those with complex PTSD. I've done it with folks who have, experienced childhood sexual abuse and have had multiple traumas since then. And so it's not limited to like a single incident trauma.
So this is the same as desensitization, right? Therapy, or is it, and it was just renamed, or is that something completely different?
You mean EMDR? Movement desensitization?
No, like desensitization. I think I'm just switching the words around.
Yeah.
Yeah.
It's basically, yeah.
Okay.
I think that's.
I've heard some colleagues call it desensitization therapy, and I think that is what they are meaning.
Mm-hmm.
This is what they are meaning. So, okay, thank you.
Yeah, sure. Okay, so let's talk about the next treatment then. Okay, so yeah, so the next treatment I want to talk with you about is called cognitive processing therapy. So as you could tell, PE is very behavioral, whereas cognitive processing therapy is almost completely cognitive. So we're really focusing on the thinking part of PTSD. And in CPT, the theory is that what really drives the PTSD and prevents recovery is the stuck points, which is the trauma-related negative beliefs. So those negative beliefs about yourself and other people and the world. And what we do in CPT is we do a structured cognitive therapy to help individuals identify those thoughts and then challenge them. And again, consists of 12 sessions, and each one is 60 minutes. And our primary tool is Socratic questioning. So kind of taking that stance of respectful curiosity about how someone came to that particular conclusion, helping them explore that and see if there are any, potential flaws in their logic or any other ways of thinking about about that particular negative trauma-related belief. And we use a series of worksheets to help people do this in a structured way. And I'll show you an example of one of those worksheets. And then we address areas that are commonly impacted by trauma. So the areas that we hit on are safety, power and control, trust, and intimacy and esteem. So here's an example of one of the worksheets. This is one of the ones we build up to. We don't start off with this one right off the bat, but this is the one that we end up with to help someone do a formal cognitive restructuring process. So you can see that they start off with a description of the event. It could be the trauma itself, or it could be something that's happening in their current lives. And then they write down their stuck point, like what is it that they're telling themselves in their situation that's really keeping them stuck. And then we rate their emotions. We use these challenging questions in the middle to really kind of chip away at that thought, like what's really the evidence for this? What's the evidence against this? And these are some other prompts that we go into more detail with. Then we use problematic patterns to identify patterns that commonly come up for this individual. And then we ask them to come up with an alternative thought and re-rate their emotions. So that's an example of what it looks like. And I'll tell you a little bit about a patient that I treated with CPT. This was a Navy medic who had two colleagues that he was very close with, a husband and wife. And the wife gave birth while they were stationed overseas, and the baby was born still, and he was part of the team that was trying to resuscitate the baby, and he was unsuccessful. And when we're doing cognitive processing therapy, we really focus on thoughts that are assimilated, which means that we focus on thoughts that people are trying to change the way that they think about the traumatic event to preserve their old thoughts. So, we all have these beliefs that I'm a capable person and that I'm in control of my destiny, and the things that I do are going to be successful. So when you have a traumatic event, that can really turn it on its head if you have a profound failure to do what you set out to do. And that's what happened for this individual. He was a medic. This is part of his identity. This is someone that he really cared about. And the fact that he was unable to save this baby was awful for him. So what he ended up saying to himself was, I didn't try hard enough. I should have done something more. It must have been something I could have done. I didn't save that baby. I'm to blame. So you can see that if that's something that you're telling yourself, it leads to an enormous amount of guilt and shame. And so that was one of the primary beliefs that we targeted in our work together. And I'm going to show you another example of someone going through cognitive processing therapy and what it was like for them.
I'm sort of a student at heart, so the worksheets really helped me write down and get some thoughts down on paper that I could talk to and use with my therapy to work through a whole bunch of different traumatic events. So the traditional CPT lasts for 12 weeks, but I was in that for a lot longer, but we went through multiple different events that I wanted to work through. But it was emotionally taxing, it was relieving, it was overwhelming, it was stressful, but in the end it was great because I worked through this stuff and I'll never forget about it, but I can think about it and talk about it without being completely overwhelmed by it now.
All right, so let me get back to my slide. Sorry, I'll make that bigger next time. Any questions about CPT before I move on to the last treatment? Are you seeing my slides? Maybe I didn't slide. Let me share. There we go. Okay, so I'm going to talk about the last treatment then. Well, the last evidence-based treatment. Okay, So the last treatment that I'm going to talk about is eye movement desensitization and reprocessing therapy, which is EMDR. And this has some similarities to prolonged exposure therapy in that you go through the memory. It has 8 phases. There's history taking and preparing the client, and then assessing the target memory, the memory that you want to work on, and then processing the memory and evaluating results. One difference from PE is that you attend to the memory in brief sessions instead of in a longer period. You know, when you're doing prolonged exposure therapy, you could be going through the memory for 45 to 60 minutes. Whereas when you're doing EMDR, it's a much shorter time frame. And you also have the patient attend to a stimulus like a beeping tone or a movement during the recounting of the memory. So I will show you a clip of someone who went through EMDR and what it was like for them. There we go. And I'll try and make this big.
And one of the things she had me do was talk about one of the worst moments in the sexual assault, to remember it, to talk about it. And right after I spoke about it to her, she repeated a sentence and I had to repeat it. She said a sentence and I had to repeat it. So I'm telling her about this sexual assault where I'm choked and I get hit in the eye in the middle of the night. And right afterwards, she says, "You matter, say I matter." And I said it. It came out of the deep recesses of my being. I matter. It just came out. I matter. I had never thought of that. I matter. And it just kept coming out and coming out and coming out. It was one of the most powerful things that I had ever felt. I matter. I matter. Yeah, I loved it.
I love that video. Okay. So, any questions about EMDR before I move on? Okay. All right, so I'm going to go back to the PowerPoint. Okay. So there we go. So the problem with these treatments is that we can't deliver them in a brief treatment setting. And we know that for PTSD, one of the core symptoms is avoidance. So if you have a long delay between your referral and the actual receipt of care, then they're less likely to follow through. So it's, you know, what we've been trying to do, or what my colleagues have been trying to do, is find ways to move some of the treatment into a primary care setting so that it can happen right away. So that, you know, right when the individual discloses that they've experienced a trauma, they can start working on it and not have to remotivate themselves just to address it. If we have time, I'd love to hear from you about how much of this you think would be feasible to do in your setting, and how much, you know, it just doesn't fit into the model that you have. Oh, this is probably stuff that you already are familiar with, which is just about the high prevalence of PTSD in primary care. That up to 23% of people in primary care will screen positive for PTSD. I'm going to skip all this, although I don't want to run through my slides too quickly and then run out of stuff. But so a little bit about the work that we've done. So federally qualified health centers, as you know, are nonprofit healthcare organizations that serve uninsured and underserved individuals. And in Michigan, they serve 680,000 folks across 260 delivery sites. And the rate of recognized mental health conditions in FQHCs has risen rose almost 300% between 2008 and 2015. But there are lots of barriers to PTSD treatment. One of the big barriers is limited time to address psychological problems, and another one is difficulty getting appointments or not wanting to go to a mental health specialist. So there have been calls to enhance PTSD treatments to be briefer to fit into these kinds of settings. I'm going to skip this about dropout rate. This is another reason why we want to condense treatments, though. I'm going to skip this too. This is about the adaptation process and the importance of attending to the core functions of a treatment when you're trying to condense it or otherwise adapt it. I'm just going to get to the meat. Okay, so full prolonged exposure, in addition to imaginal and in vivo exposure, has psychoeducation and breathing retraining, which is a breathing exercise, but the core components are really the in vivo and the imaginal exposure. And the full course is 12 sessions, but my colleagues, Dr. Rausch and Dr. Seagren, have condensed this down into a 4 to 6 session protocol. And each one of these sessions is just 30 minutes and can be done by any mental health provider in the primary care setting. So I'll talk a little bit more about each of these sessions, but you can see just from an initial glance that we introduce the core components right at session 1, so that we're making sure that folks have access to those effective components right off the bat. The first session, or session 0, is optional, and I actually wonder if this might be something that that could be done even if you just have one visit with a patient. As I was putting my slides together, I was kind of curious about that. But what you do in a session 0, whether or not you are proceeding with the rest of the sessions, is you do a little bit of a longer assessment. The PCL-5 is what we typically use, which is a 20-item questionnaire that just goes through the symptoms in a little more detail. And then once someone's filled that out, you can really go through the symptoms with them and use the opportunity to do some motivational interviewing to highlight the discrepancy between their values and their behavior or their current circumstances. So we talk about the re-experiencing symptoms and how those can be, really upsetting and distressing and often lead to avoidance. Then with the avoidance, we talk about how that this is really the engine that drives PTSD, and the way that avoidance is helpful in the short term, but oftentimes is not helpful in the long term, that it doesn't make things easier over time if you keep avoiding. And we also talk about how when you avoid the things that that remind you of the trauma, you end up avoiding a lot of the things that are important and valuable to you as well. Then when we talk about the negative alterations in mood, we talk about how this really can interfere with relationships and can kind of prevent you from doing the things that you love to do. And we make a point to draw out what are the things that you used to like doing or that you used to enjoy that you no longer feel able to because of the PTSD. And then when we talk about the hyperarousal, we talk about this as something that could have at one point been adaptive for you, could have been helpful in a given setting, especially if with our veteran patients, but that right now is not helping you, and that is often pretty exhausting. So when you review the symptoms with someone, we try to both provide the psychoeducation and also highlight the need for change and get some concrete examples of how the PTSD is interfering in their life that we can use to help them with later on. And then the next session is about talking about the treatment components in more detail. The narrative exposure is like imaginal exposure, but it's written out to save time. So you give the patient a packet and then they write out their narrative at home, so that those session can be used for emotional processing. And when we describe a narrative exposure, we do this in full PE too, but we talk about the messy closet metaphor, or at least this is the metaphor I've used that I think folks respond to the best, which is that your trauma memory is kind of like a really messy closet, and you stuff everything in there because you don't want to think about it, don't want to look at it, and slam the door shut. But because it's so full, the door keeps popping open and things keep falling out all over the floor. And every time that happens, it's really shocking and startling, and you throw everything back in, slam the door closed again. So what we do in this treatment is we actually open the closet door, we take a look at everything that's in there, We sort it out, we throw away the things that don't belong there, we organize the things that do belong there, so that afterwards the closet is much less likely to pop open. And if it does, it's not scary because you know everything that's in there and you know how to put it back. But I found that patients respond well to this metaphor. We also talk about in vivo exposure and how this is really helping you to take back your life from PTSD and not letting the PTSD define you or not letting the PTSD control you anymore. And then we just assign homework for the week. Then at all the subsequent sessions, basically what you're doing is you're reviewing the homework, how it went. You're asking the veteran, oh, I should mention that in terms of the narrative exposure, you ask someone to write their narrative for 30 minutes on the first day. And then on the other days of the week, they're going to read it over to themselves so they get practice with confronting and approaching the memory. So when they come back into session the next week, you have them read their narrative out loud, read their responses to the emotion processing questions. And then you do some emotion processing with them, which is guided by the patient. It's mostly where they want to go with it and how the memory has affected them, how the trauma has affected them. And as a therapist, you are trying to help them contextualize it a little bit more and put it in context. And that's pretty much it. We have, so running out of time. So the randomized control trial of this treatment that was done by Dr. Siegring and Dr. Rausch found that this was very effective compared to standard collaborative care or PCMHI care. And dropout was only 10%, which is really big for PTSD because we tend to have high dropout rates. And I did this treatment in 30 patients in Michigan FQHCs. We ended up enrolling 30 people. And I'm not going to go over the demographics, but it was a pretty disadvantaged sample or disadvantaged population that we reached. And in our intent to treat sample, the mean PTSD score dropped 18 points and depression score dropped 5 points. And then among those that attended at least one session, we got a drop of 25 points on the PTSD checklist. So this treatment was effective for our individuals who went through.
And what drop is considered clinically significant?
Yes, thank you for asking. So a 10-point decrease is considered clinically significant. So in the whole sample, we got 18 points. So and those who initiated treatment or had at least one session got 25 points. So the average was well above that threshold for clinically significant change. So I'm going to stop there. I have some more slides, but I would love to hear from you whether a 4 to 6 session treatment is something that would be feasible in your setting, or whether it's feasible to have like a single session where you sort of set the stage for this kind of treatment, or what would work in your settings.
Hi, this is Dorian Espiritu from Henry Ford. Thank you so much for this. Very, very helpful. Number one, we don't have, the PTSD treatment in the behavioral health integration. So all of the patients who would have a PTSD diagnosis would need to be referred back to behavioral health services. And we don't have a PTSD clinic. We did send, several therapists several years ago to the Beck Institute for the training. But again, they're seeing all sorts of patients, so it's not really a focused PTSD. So this would, really be a very helpful treatment, because we do have a lot of patients who have traumatic experiences in primary care, and we are offering about 6 to 8 sessions anyway. So I think this would be a really good, approach. The other part is, do you use the PTSD Coach app at all, and how useful or how helpful is that? Because I do prescribe it a lot, but it's difficult for me to really, track the usability. It's like, yeah, I did one, this, and then it's just like, okay, where are we in terms of, the treatment? So
yeah,
thank
okay,
you.
great. Okay, yes, definitely. So I think that the PTSD coach can be a great option too. So this is a mobile app. I was going to put this in and then I didn't. So it's a mobile app. It has a lot of good self-care strategies and coping strategies, sort of general coping. I would say that it's particularly useful for some of those more mild presentations because it has a lot of good things like relaxation and sort of monitoring your symptoms and coming up with strategies to help manage your mood. So I think it's a really good sort of light touch. For folks that might need a little bit more, I think that's when you might want to try to do some of the more active treatments. And the one thing that I sometimes worry about a little bit with PTSD coach is that sometimes I feel like it kind of inadvertently send the message that if you're feeling distressed, you need to do something else to distract yourself, which is not the message that we would send with PE or PEPC. But having said that, there have been randomized controlled trials with PTSD coach that shows that it does have a medium effect size, and so for a lot of folks that can be enough.
Thank you.
Sure.
And then I was just wondering, is there like a place, a resource where we can find evidence-based CBT clinics? I mean, PTSD clinics. I had a patient who actually had to take out a loan because he was promised that this was the best PTSD treatment. And it was awful. Went for 3 sessions. Obviously it wasn't. It was, unfortunately just, one of those fad stuff that, so would there be one that like we could look into when we're sending patients to?
Yeah, so I would say I would check out the ADAA website. That's the Anxiety Disorders Association of America. They have a therapist listing. And it's a good website, but there isn't that much availability on there. In Michigan, I've looked, but that would be one place to check. And then the ABCT website is pretty good too. That's the Association for Behavioral and Cognitive Therapy. And that has therapist listings as well.
Thank you.
Sure.
Becca, this is Pat Ryan again. I'm just wondering, did you find any kind of consistent negative effects with some people? So we're always like, oh no, if we start to bring all the trauma up and we don't have stuff we're going to help them with, what's going to happen? And I know in my experience, there's been people who have done very well with the prolonged exposure and the EMDR, and then some people who just kind of fall apart when you start to do that. So I'm just wondering if you guys looked at that and what you found with that in this primary care setting.
Sure. So we did interviews. So first of all, I will say that, this is a smaller study, but there have been, quite a few studies looking at full prolonged exposure therapy and this idea of symptom worsening. And it is true that for some people, there can be a worsening of symptoms temporarily. But what these studies have shown is that it's not a long-term effect. So for most folks who do experience a symptom exacerbation, they will then go on to improve. So they'll have like a temporary increase and then they get a lot better. There are some folks, as with any treatments, there are some folks that it doesn't work all that well for, but they're not worse when they come out than they were at the beginning, if that makes sense. And then in terms of this pilot, we didn't see anyone who had who ended up with a higher PTSD score at the end than they did at the beginning. And we also interviewed 10 people about their experiences. We did some semi-structured interviews. Running out of time, sorry. And it was really interesting to hear what they had to say, because those who went through the therapy, I think I have it actually. Yeah, they said, they had positive effects. They said they were less frustrated, they weren't angry. Some did say, there were a few people who said it was intense, that like they'd done PTSD treatment before, but with this one, they got right into it, which is true because, we started off right at session 1 with doing the exposure. So some people said it was more intense than other treatments that they'd had. And I think I would acknowledge that is true.
Great, thank you.
Sure.
Well, I think that's interesting looking at that slide where you said the FQHC providers wanted more training and to be able to do it. You're talking about the primary care docs themselves?
So these were, here, I'll bring up the slide again. These were behavioral health providers.
Okay.
Who, so we didn't talk to the primary care providers for the quality of nurse. We talked to the behavioral health providers here.
And I believe most of them were behavioral.
Courtney did a lot of these interviews too.
So several of the sites that we were in for Transform, they were also doing collaborative care in.
Yeah. Yes, I should mention that Courtney was a big part of the study, and yes, and we couldn't have done it without her. All right, well, I don't want to take up too much of your time, but thank you so much for having me, and please feel free to email me if you have any questions. I'd be happy to follow up. And it was nice meeting all of you.
Thank you. That was
Thank you very much, Becca. That was fantastic.
All right, have a good weekend, everyone.
Thank you.
Take care.
You too.
Take
Thank
care,
you.
all.
Take care, everyone. Happy New Year.
Bye.
Happy New Year. Happy Friday.
Happy Friday. Bye.
Bye.
Thank you again, Becca. That was really